Welcome to Refractive Surgery. In this chapter, we're going to focus on the science that underpins refractive surgical procedures, rather than jumping straight into techniques or technologies. The goal here is to build a solid conceptual foundation: how the eye focuses light, how refractive error arises, and how surgical interventions modify ocular optics to achieve clearer vision. As we move through this chapter, keep in mind that every refractive procedure, regardless of how advanced it looks in the operating room, is ultimately an application of these basic optical and biomechanical principles.
Before diving into details, this slide frames the major themes of the chapter. Refractive surgery isn't a single operation or technology, but a collection of surgical techniques designed to reduce a patient's dependence on glasses and contact lenses. Understanding how and why we choose among these options requires familiarity with the diagnostic tools that guide decision-making. Wavefront analysis plays a key role by characterizing higher-order aberrations. This information helps tailor custom ablation profiles and also provides a physiological explanation for patient-reported visual symptoms that aren't captured by simple refraction alone. Corneal topography and tomography are equally central. They are critical for preoperative screening, particularly to identify corneas at risk, and they become indispensable postoperatively when outcomes are unexpected and require careful analysis. Finally, all keratorefractive procedures rely on fundamental laser-tissue interactions. These interactions fall into three categories: photoablative, photodisruptive, and photothermal, and understanding these mechanisms sets the stage for how different refractive platforms achieve their intended effect on the cornea.
We'll start by framing what refractive surgery is actually trying to accomplish. At its core, the goal is not perfection on a chart, but reducing a patient's dependence on glasses or contact lenses for their everyday life. That's the practical outcome patients care about, and it's the lens through which all refractive procedures should be viewed. There are many different surgical techniques and technologies available to reach this goal, and throughout this section, we'll be comparing how and when each of them is used. The important point early on is that refractive surgery is not a single operation, but a toolbox, and choosing the right tool matters as much as the tool itself. Because of that, careful preoperative evaluation becomes essential. Using the appropriate diagnostic testing allows us to decide who is actually a good candidate and who is not, and just as importantly, it helps us optimize refractive outcomes for those we do treat. This idea of patient selection and individualized planning is going to come up repeatedly as we move forward.
Now that we've established the overall goal of refractive surgery, the next step is to organize the different procedures conceptually. Broadly, refractive surgical procedures fall into three major categories based on where the optical change is being made. The first group includes corneal procedures, where we alter the shape or optical properties of the cornea to change refraction. The second category is scleral procedures, which are less commonly used today but are still important to understand historically and conceptually. The third group is intraocular procedures, where refractive correction is achieved by placing, removing, or exchanging a lens inside the eye. Keeping these categories in mind is helpful because as we go through individual techniques later on, you'll see that patient selection, risk profiles, and long-term considerations differ substantially depending on which category a procedure falls into.
Here is a quick review of the different types of keratorefractive procedures, which are the corneal-based approaches to refractive surgery. These procedures all work by modifying the cornea, either by changing its shape, its biomechanics, or its optical properties, in order to achieve a refractive effect. One subgroup includes incisional procedures, where strategically placed cuts in the cornea alter its curvature. Another major category is laser ablation procedures, where tissue is removed in a highly controlled way to reshape the cornea. A more recent development is refractive lenticule extraction, which includes techniques such as relax, flex, and smile, where a lenticule of stromal tissue is created and removed to change corneal power. In addition to these, there are corneal inlays and onlays, which modify the optical system by adding material rather than removing tissue. Corneal collagen shrinkage techniques take advantage of thermal effects to induce refractive change, while corneal cross-linking techniques focus on altering corneal biomechanics, primarily for stability, with refractive effects in select situations.
We can also broaden the discussion to scleral and intraocular refractive procedures. These techniques achieve refractive change without primarily reshaping the cornea, and they come with a different set of indications and trade-offs.
Scleral procedures include approaches such as scleral implants and laser excision of the anterior ciliary sclera. These methods have historically been explored to influence ocular biomechanics or accommodation, but they are used far less commonly in modern practice. In contrast, intraocular refractive procedures play a major role in current refractive surgery. One option is phakic intraocular lens implantation, where a lens is placed inside the eye while the natural crystalline lens is left in place. Another major category includes cataract surgery, or refractive lens exchange, where the natural lens is removed and replaced with an intraocular lens. These intraocular lenses can be monofocal, toric, multifocal, accommodative, or extended depth of focus designs, each offering different visual trade-offs. The key concept to carry forward is that every technique has distinct advantages and disadvantages, and successful refractive surgery depends on matching the procedure and lens choice to the individual patient, rather than forcing a single solution on everyone.
At this point, it's important to narrow the scope of what we'll be covering in this chapter. The focus here is specifically on keratorefractive procedures, so while scleral and intraocular options are important, they won't be the primary emphasis going forward. This chapter is designed to provide an overview of several foundational concepts that are essential for understanding corneal refractive surgery. That includes fundamental corneal properties, the imaging modalities used in refractive surgery planning, and the ways refractive surgery alters the cornea structurally and optically. We'll also be reviewing key principles that underpin clinical decision-making. These include core optical concepts from BCSC Section 3, an understanding of refractive errors ranging from lower-order to higher-order aberrations, and the role of corneal biomechanics. In addition, we'll cover corneal topography and tomography, wavefront analysis, the biophysics of laser tissue interactions, and the basics of corneal wound healing. All of these concepts will come together as we start discussing individual procedures and their outcomes. Now we'll turn to corneal optics and where refractive power in the eye comes from. Most of the eye's optical power is generated at the air-tear interface and by the curvature of the cornea, which explains why the cornea is so central to refractive surgery. In a healthy eye, the tear film has minimal impact on vision quality because it creates a smooth optical surface. When the tear film is abnormal, such as with dry eye, epiphora, or blepharitis, visual quality can be significantly degraded, even if the cornea itself is otherwise normal. The anterior corneal surface provides roughly 2/3 of the eye's total refractive power, contributing about +48 diopters, while the posterior corneal surface contributes negative power, around -6 diopters. Together, this results in a net total corneal power of approximately +42 diopters. Now we'll focus on corneal curvature, how it's measured and why it matters surgically. Keratometers and placido-based topography primarily measure the anterior corneal curvature, and from that front surface data we estimate total corneal power. Central corneal power, or K, is extrapolated from curvature changes in the paracentral 3 to 4 mm zone. This becomes especially important after keratorefractive surgery because errors in estimating K can directly affect intraocular lens power calculations. In a normal cornea, curvature gradually flattens from the center toward the periphery by up to about 4 diopters. The cornea is typically flatter nasally than temporally, and the overall shape is described as prolate. Keratorefractive surgery works by changing corneal curvature, and even very small alterations can have large refractive effects. For example, a roughly 2 diopter change may require less than 30 microns of tissue alteration. Because these tolerances are so small, achieving precise and predictable outcomes can be challenging, which is why accurate measurement and careful planning are critical. This figure illustrates the different corneal shape profiles that are relevant in refractive surgery. On the left is the prolate cornea, which represents the normal corneal shape. In this configuration, the cornea is steeper centrally and gradually flattens toward the periphery, which is optically efficient and minimizes aberrations. In the middle is the oblate cornea, which is commonly seen after myopic ablation. Here, the central cornea becomes flatter, while the peripheral cornea is relatively steeper. This shift in shape helps correct myopia, but can also be associated with increased higher-order aberrations if not carefully controlled.
On the right is the hyperprolate cornea, which is typically seen after hyperopic ablation. In this case, the central cornea becomes steeper relative to the periphery. Understanding how refractive procedures move the cornea from a prolate toward an oblate or hyperprolate shape is essential, because these shape changes directly influence visual quality, aberrations, and patient satisfaction.
Next, we'll move into refractive error through the lens of optical principles and wavefront analysis. Wavefront analysis applies wave theory of light to clinical refractive assessment, allowing us to describe how light is distorted as it passes through the optical system of the eye. Clinically, this can be performed using several different techniques, including Hartmann-Shack sensors, churning methods, thin beam single ray tracing, and optical path difference measurements. Although the technologies differ, they are all aimed at characterizing the same underlying optical behavior. All of these methods generate detailed measurements of refractive error, capturing both lower-order aberrations, such as sphere and cylinder, and higher-order aberrations, including spherical aberration, coma, and trefoil. This information is then used to design custom ablation profiles, improve visual outcomes, and help explain visual symptoms that may not be accounted for by standard refraction alone.
Think of wavefront measurement as a way of mapping how smooth or distorted light is as it comes out of the eye. This is most commonly done with a Hartmann-Shack wavefront sensor. A very low-power laser is focused onto the retina, and the reflected light then travels anteriorly back through the eye. As it exits the eye, that light carries information about the eye's optical system. In a perfect optical system, the emerging rays would be parallel and the wavefront would be flat, like a smooth sheet. In real eyes, the wavefront is distorted. To measure this distortion, the outgoing light passes through an array of tiny lenslets, which sample the wavefront across the pupil. Each lenslet focuses light to a small spot on a detector. If the optics were perfect, all of those focal points would land exactly where they are expected. When the wavefront is distorted, those focal points are shifted. The amount and direction of this displacement tells us how the wavefront is warped at that location. By adding together the measurements from all of the lenslets, the system reconstructs the total wavefront error as the sum of multiple basic aberration shapes, allowing us to describe both lower-order and higher-order aberrations in a way that is clinically useful.
Now that we've talked about how wavefront aberrations are measured, the next step is understanding how that information is actually represented and interpreted. Once the Hartmann-Shack sensor samples the wavefront with its array of lenslets and measures the local distortions, all of that raw data needs to be translated into something clinically meaningful. That's where Zernike polynomials come in. They provide a standardized way to describe the shape of the wavefront by breaking a complex distortion into simpler, named components that we can quantify, compare, and relate directly to visual quality. Each polynomial represents a specific type of distortion in how light is focused. Each Zernike term has a coefficient that can be positive or negative, and the sign tells us the direction of the distortion, while the size of the number tells us how strong that distortion is. Because of this, each term produces a predictable change in image quality. To describe how big the overall distortion is, we use something called root mean square, or RMS error. You can think of RMS as a single number that summarizes how bumpy the wavefront is overall. A higher RMS value means more total aberration. In most patients, the RMS for higher-order aberrations is less than about 0.3 microns when measured over a 6 mm pupil. Not all Zernike terms affect vision equally. The ones that most strongly impact visual quality include defocus, which corresponds to myopia or hyperopia, spherical aberration, coma, and secondary astigmatism. Understanding which Zernike terms are elevated helps explain a patient's visual symptoms and guides how we think about refractive correction. The image in the bottom right of the slide is a visual way to show what a single Zernike term looks like, specifically defocus. You can think of this surface as a map of how the wavefront is shaped as it exits the eye. The height and color represent how early or late light is arriving at different points across the pupil. When the surface is shaped like a smooth dome, as shown here, that pattern corresponds to defocus. In practical terms, this is what myopia or hyperopia looks like in wavefront space.
The entire wavefront is uniformly too steep or too flat, rather than being twisted or irregular. Because the distortion is smooth and symmetric, defocus is a lower-order aberration and is the easiest type of error to correct with glasses, contact lenses, or standard refractive surgery. This figure helps reinforce the idea that Zernike polynomials are not abstract math, but simple geometric shapes that directly correspond to familiar refractive errors and predictable visual effects. So far, we've focused on Zernike polynomials, but they're not the only way to analyze aberrations. Fourier analysis is an alternative approach. Instead of using named shapes like defocus or coma, Fourier analysis breaks the optical surface into combinations of sine wave-derived patterns. This can provide a more detailed description of the surface than Zernike analysis. Because of that added detail, Fourier methods may be especially useful for analyzing highly aberrated corneas, where Zernike models may be less accurate.
Now we'll focus on lower-order aberrations, which are the second-order aberrations and make up the bulk of what we correct clinically. These include myopia, hyperopia, and regular astigmatism. In wavefront terms, myopia and hyperopia are both forms of defocus. Myopia corresponds to positive defocus, meaning the wavefront is too steep, while hyperopia corresponds to negative defocus, meaning the wavefront is too flat. Regular or cylindrical astigmatism occurs when the wavefront has different curvature in different meridians. This is represented by orthogonal and oblique components, which together describe the familiar bow-tie pattern seen on topography and wavefront maps. There are also lower-order aberrations that are less clinically relevant. First-order aberrations include vertical and horizontal prism, which generally do not affect visual quality in a meaningful way. Zero-order aberration, called piston, represents a uniform shift of the wavefront and has no effect on image formation at all. The key point is that lower-order aberrations account for the majority of refractive error and are the most straightforward to measure and correct. Now we'll zoom out and look at higher-order aberrations as a group. Higher-order aberrations become more noticeable as pupil size increases, which is why they tend to cause symptoms in low light conditions when the pupil dilates. They also increase with age, although the clinical impact of that increase can be partly offset by age-related meiosis, since a smaller pupil masks peripheral aberrations. After refractive surgery, there's an important trade-off to understand. Lower-order aberrations, like sphere and cylinder, usually decrease as intended. At the same time, higher-order aberrations can increase, particularly spherical aberration and coma, depending on the procedure and ablation profile. These increases are most commonly seen after surface ablation, myopic LASIK, and radial keratotomy. This explains why some patients may achieve excellent visual acuity on the chart, but still report glare, halos, or reduced quality of vision, especially at night. Understanding this balance is key when counseling patients and choosing surgical techniques.
Let's talk about the key types of higher-order aberrations, starting with spherical aberration. Think of spherical aberration as what happens when light coming through the edges of the pupil behaves differently than light coming through the center. In spherical aberration, the peripheral rays focus in front of the central rays, instead of all meeting at the same point. Because this pattern is the same all the way around the pupil, it's described as a radially symmetric fourth-order aberration. This type of aberration is especially important clinically because it has very noticeable visual effects. Patients may experience night myopia, where vision seems worse in dim light, and halos around point light sources, such as headlights at night. These symptoms become more obvious as the pupil gets larger. Spherical aberration is commonly increased after procedures like radial keratotomy and myopic LASIK, where the corneal shape is altered in a way that affects how peripheral rays are focused. Among the higher-order aberrations, it's the most clinically significant one. At lower levels, spherical aberration can actually increase depth of focus, which can be helpful in certain situations. But as it increases, it reduces contrast sensitivity, meaning images look less crisp, even if visual acuity on the chart is good. The image helps visualize this concept by showing a smooth, bowl-shaped wavefront where the center and periphery are at different heights, representing the mismatch in focus between central and peripheral rays.
Now we'll look at two other key higher-order aberrations, coma and trefoil, and the pictures help make the differences clear. Coma is a third-order aberration, and happens when one side of the pupil focuses light differently than the opposite side. Instead of light coming to a single point, the image gets pulled in one direction. Clinically, this produces a coma-shaped or smeared image, which is where the name comes from. Patients often describe this as streaking or flaring of lights. Coma is commonly seen in conditions where the optics are asymmetric. Classic examples include keratoconus, decentered corneal grafts, and decentered laser ablations. In all of these cases, the problem isn't uniform blur, but imbalance across the pupil. The image on the slide shows this asymmetry, with one side of the wavefront elevated and the other depressed, reflecting uneven focusing.
Trefoil is also a third-order aberration, but it behaves differently. Instead of a one-sided distortion like coma, trefoil has a three-lobed pattern. It can occur after refractive surgery and represents a more evenly distributed but still irregular distortion of the wavefront. Compared to coma, trefoil tends to cause less image degradation for the same RMS magnitude. Even though the numerical amount of aberration may be similar, patients are often less symptomatic. The trefoil image shows this repeating three-fold pattern, which helps explain why the visual effect is usually less dramatic than the directional smearing seen with coma. The key takeaway is that not all higher-order aberrations are equal. Coma tends to be more visually disruptive, while trefoil, although still important, is often better tolerated clinically. There are many different higher-order aberrations that can be mathematically described, far more than the few we routinely talk about. In current clinical practice, only a small number of these are consistently relevant because they have the biggest impact on visual quality and patient symptoms. That said, this is an evolving area. As our understanding of surgically induced aberrations improves, and as diagnostic and treatment technologies become more precise, additional higher-order aberrations may become clinically important in the future. The key idea is that what matters clinically today may expand as both surgery and optics continue to advance. Now we'll talk about how excimer laser ablation affects higher-order aberrations, because this is where surgical technique really matters. With conventional excimer laser ablation, higher-order aberrations are typically increased rather than reduced. The amount of increase tends to correlate with how large the preoperative refractive error is, meaning bigger corrections generally induce more aberrations. In myopic ablations, tissue is removed centrally, which makes the cornea more oblate. This shape change tends to induce positive spherical aberration, where peripheral rays focus in front of central rays. This is a common reason patients report halos or reduced night vision after myopic LASIK. Hyperopic ablations work differently. The laser is applied to the mid-peripheral cornea rather than the center, which increases central curvature. This creates a hyperprolate cornea and tends to generate negative spherical aberration. When we compare these conventional treatments to more modern approaches, the differences are important. Wavefront optimized, wavefront guided, and topography guided ablations are designed to better control higher order aberrations. These techniques may reduce the amount of surgically induced HOAs, may reduce pre-existing aberrations, and can improve overall visual quality, particularly under mesopic conditions when the pupil is larger. The key takeaway is that excimer laser ablation doesn't just change refraction, it reshapes the optical system in ways that directly influence higher-order aberrations, and newer customization strategies aim to minimize those unintended effects. Now we'll shift into corneal imaging and why it's so central to keratorefractive surgery. The goal of corneal imaging is to understand corneal shape, curvature, and thickness in a way that helps guide surgical decision-making. This is done using several different imaging technologies, each of which provides a different type of information. Corneal shape and curvature are commonly assessed using placido disc-based systems, which analyze reflections from the anterior corneal surface, and elevation-based systems, which measure the cornea in 3 dimensions. Elevation-based systems include scanning slit technologies and Scheinflug imaging, which allow us to assess both anterior and posterior corneal surfaces as well as corneal thickness.
Because each technology measures the cornea differently, each one tells us something slightly different. Together, they give information about corneal curvature, corneal anatomy, and aspects of corneal biomechanical function. Modern topographic and tomographic systems also provide additional clinically useful data. These may include pupil size and location, indices of regular and irregular astigmatism, keratoconus risk estimates, simulated keratometry values, and measurements of corneal asphericity. Some platforms also integrate wavefront aberrometry with corneal topography to link optical quality with corneal shape. Despite how advanced these systems have become, the key point is that no automated screening tool replaces clinical judgment. Imaging guides decision-making, but it doesn't make decisions for us.
Now we'll talk about corneal asphericity and how it's summarized by the Q value, which is a simple way to describe overall corneal shape. The Q value tells you whether the cornea is shaped more like a sphere or whether it changes curvature from the center to the periphery. A Q value of 0 represents a perfectly spherical cornea. When the Q value is less than 0, the cornea is prolate, meaning it is steeper in the center and relatively flatter in the periphery. When the Q value is greater than 0, the cornea is oblate, meaning the periphery is relatively steeper compared to the center. From a clinical standpoint, the normal cornea is prolate, with an average Q value of about -0.26. This prolate shape is optically efficient because it helps minimize spherical aberration by keeping peripheral rays better aligned with central rays.
When the cornea becomes oblate, the likelihood of positive spherical aberration increases. This is why oblate corneas are often associated with glare, halos, and reduced visual quality, especially in low light. Oblate shapes are commonly seen after myopic laser ablation, where central flattening shifts the cornea away from its normal prolate configuration. The key point is that the Q value gives you a compact way to link corneal shape to optical performance, and changes in Q help explain why certain refractive procedures improve acuity but can still affect visual quality.
Now we'll go over the basic principles behind corneal topography. Corneal topography provides detailed information about corneal curvature. It's generated from keratoscopic images created by Placido disc patterns, also called Myers, that are reflected off the tear film on the anterior corneal surface. The system analyzes how those rings are distorted to infer corneal shape. That reflected information is then converted into computerized color curvature maps, which give us a visual representation of how steep or flat different areas of the cornea are. Because this imaging depends on reflections from the anterior tear film surface, tear film quality and volume matter a lot. An unstable or irregular tear film can significantly affect accuracy, which is why topography can look abnormal in dry eye even when the cornea itself is normal. For that reason, the raw Placido image quality always needs to be reviewed before interpreting curvature maps or numerical values. Poor ring capture or distorted Myers can make the data unreliable. Another important point is that measurements are referenced to the instrument's vertex normal, not necessarily the patient's visual axis or line of sight. If those axes don't align, it can lead to interpretation errors, especially when evaluating symmetry and centration.
This image shows how Placido-based corneal topography actually works and how the data are generated. In the top panel, you're seeing the Placido device projecting a series of concentric rings, or Myers, onto the patient's cornea. Those rings reflect off the anterior tear film surface. If the cornea is smooth and regular, the rings look evenly spaced and symmetric. Any distortion in the rings reflects differences in corneal curvature. That reflected image is then captured by the system and analyzed. In the bottom panels, you can see how the same Placido data are converted into different types of maps. Axial and tangential curvature maps show how steep or flat the cornea is in different regions, using color to represent curvature. Warmer colors indicate steeper areas, and cooler colors indicate flatter areas. You can also see an elevation map, which compares the corneal surface to a reference shape and highlights areas that sit above or below that reference. In the lower right, the actual ring image is displayed, which is critical to review before trusting any of the maps. The key point this figure reinforces is that all of this information starts with the quality of the reflected Myers. If the tear film is irregular or the rings are poorly captured, the derived maps can be misleading. That's why reviewing the raw Placido image is just as important as interpreting the color maps themselves.
Now we'll talk about how to read corneal topography maps, starting with color scales, because how the data are displayed can completely change how the map looks. On corneal topography, curvature is shown using color-coded scales. Warmer colors, like red and orange, represent steeper curvature, while cooler colors, like green and blue, represent flatter curvature. That basic color logic is consistent across systems, but how those colors are assigned depends on the scale being used. With an absolute or standard scale, the color coding is fixed. Typically, the scale runs from about 35 to 50 diopters, with roughly 1.5 diopters per color step. The key advantage is that the same color always represents the same dioptric power, which allows direct comparison between different maps, different eyes, or different visits. A normalized or relative scale works differently. Instead of using fixed diopter values, the scale spreads across that individual eye's total dioptric range. This provides greater local detail and can make subtle changes easier to see. The trade-off is that you have to pay close attention to how much dioptric change each color represents, because the colors no longer correspond to fixed powers. Improper scaling can be misleading. If the color steps are too large, true abnormalities can be masked and the map can look falsely normal. If the steps are too small, the map can look overly dramatic and artificially smooth, exaggerating minor variations. The key point is that before interpreting any topography map, you always need to check the color scale. Otherwise, you may be reacting to the display settings rather than the actual corneal shape.
Now we'll focus on axial power maps and the assumptions built into them, because those assumptions explain both their strengths and their limitations. Axial power is calculated based on the assumption that the cornea is spherical and that the instrument's measuring beam is normal to the corneal surface. The curvature is derived from the concept of axial distance, meaning how far each point on the cornea is from a single reference axis. Because of these assumptions, axial power tends to underestimate areas that are truly steep and overestimate areas that are flatter. In other words, it smooths out extremes rather than showing abrupt local changes. Axial maps are also highly dependent on which reference axis is used. Using the optical axis versus the visual axis can produce very different maps for the exact same cornea, even though the anatomy hasn't changed at all. This is an important source of potential misinterpretation. Finally, because axial power averages corneal power over a broader area, these maps have a smoother, more uniform appearance compared with tangential or instantaneous maps. That smoothness can be helpful for getting a general overview of corneal shape, but it can also hide localized abnormalities. The key takeaway is that axial power maps are useful for global pattern recognition, but they should not be relied on alone when subtle or focal corneal changes matter.
Think of this picture as showing two different ways to measure how curved the cornea is, and why one of those ways can be misleading. Each point on the cornea has its own true curve, and that curve has a center, shown here as C1 and C2. If you measured curvature the local way, you would look straight from each corneal point to its own center of curvature. That tells you how steep or flat that exact spot really is. Axial power works differently. Instead of measuring each point on its own, it measures distance to a single reference axis, shown by the horizontal line. Points A1 and A2 are where those measurements end on that reference axis. This means every point on the cornea is being forced to relate back to the same axis, even though the cornea itself isn't perfectly spherical. Because of that shortcut, steep localized areas end up looking less steep than they really are, and flatter areas end up looking flatter than they should. In other words, axial measurements smooth things out. That's why axial power maps look smooth and symmetric, and why they're good for getting a big picture view of corneal shape. But this figure also shows why axial power can miss small focal abnormalities, because it's averaging everything back to one reference axis, instead of measuring each point on its own.
Now let's talk about the limitations of axial power maps and what that means clinically. Placido-based systems don't directly image the very center of the cornea, roughly the central 1 to 2 millimeters. Axial power maps try to fill in this gap by approximating that region, but those values are extrapolated rather than directly measured. That's why axial power was historically referred to as sagittal curvature. It's an estimate based on assumptions, not a true local measurement. Because of this, axial power does not accurately represent the true corneal shape, especially outside the center. It also fails to show the true refractive power of the peripheral cornea. Steep or irregular areas in the periphery tend to be smoothed out or misrepresented. That said, axial power maps are still useful. They provide an intuitive, easy-to-read depiction of normal physiological corneal flattening from the center to the periphery, which makes them good for recognizing broad patterns and symmetry. The key limitation to keep in mind is that axial power does not reflect true peripheral curvature or true peripheral refractive power. It's a global, averaged view of the cornea. So, while it's helpful for orientation, it should not be relied on when precise or localized corneal detail matters.
Now we'll define instantaneous power, also called tangential or meridional power, and contrast it with axial power. Instantaneous power describes corneal curvature at a specific point, using the instantaneous radius of curvature at that exact location. Instead of referencing everything back to a single axis, it looks at how curved the cornea is right where you're measuring it. The radius is determined by drawing a perpendicular path through the point of interest relative to the visual axis. That local radius corresponds to a sphere that has the same curvature as the cornea at that one point. Curvature, expressed in diopters, is calculated using the difference between the corneal refractive index and 1.000, divided by that tangentially determined radius. Importantly, these diopters represent relative curvature rather than true corneal refractive power. The key idea is that tangential power is a local measurement. It captures focal changes in curvature much more accurately than axial power, which is why tangential maps are better for identifying small, localized abnormalities on the cornea.
Now, let's talk about the strengths and limitations of instantaneous or tangential power maps, because this is where interpretation really matters. Instantaneous power maps are much more sensitive to peripheral and localized changes in corneal curvature. They apply less smoothing than axial maps, which allows them to highlight subtle shape irregularities that might otherwise be hidden. That increased sensitivity is a double-edged sword. While it makes these maps excellent for detecting focal abnormalities, it also introduces more noise. Some of the fine detail you see may not be clinically relevant and can reflect measurement variability rather than true pathology. Because of this trade-off, most surgeons rely on axial maps for routine refractive screening, where a smooth, global overview is helpful. Instantaneous maps are typically used as a problem-solving or confirmatory tool, especially when something on the axial map looks suspicious or when subtle irregularity needs to be better defined. The key takeaway is that tangential maps are powerful for detail, but they require careful interpretation to separate meaningful findings from noise.
This slide is putting everything we've talked about together by showing how different maps describe the same cornea in very different ways, especially in an irregular eye like keratoconus. On the left, you can see the placido image itself. The concentric rings, or mires, are clearly distorted rather than smooth and evenly spaced. That distortion already tells you the corneal surface is irregular before you even look at any color maps. Below that are multiple maps generated from the same data. Even though they all come from the same eye, they emphasize different things. The axial curvature map looks relatively smooth and symmetric. It gives you a general sense of steepening, but it averages curvature and softens localized changes. This can make an irregular cornea look more orderly than it really is. On the right side of the slide, the axial and the tangential map are shown side by side. The axial map again looks smoother and more centralized because it's based on assumptions and averaging. In contrast, the tangential map highlights sharper, more localized areas of steepening. This is where the true focal abnormalities stand out much more clearly. In keratoconus, that difference is critical. The tangential map better reveals where the cone actually is and how steep it truly becomes, while the axial map is better for recognizing the overall pattern and orientation. The key lesson from this figure is that no single map tells the whole story. Axial maps are useful for global screening and pattern recognition, but tangential maps are better for identifying localized pathology. Interpreting corneal topography means understanding what each map is showing, and just as importantly, what it's smoothing over or hiding.
This slide shows what normal corneal topography looks like and how it changes with regular astigmatism. In a normal cornea without astigmatism, the map shows a relatively uniform color in the center, with gradual physiological flattening as you move toward the periphery. The pattern is smooth and symmetric, without focal areas of steepening or irregularity.
With regular astigmatism, the cornea is steeper along one meridian and flatter along the meridian 90 degrees away. Because that steepening is uniform and follows a single axis, it's fully correctable with cylindrical lenses. On topography, this appears as a symmetric bow tie pattern. The two lobes are aligned along a single straight axis and are mirror images of each other on either side of the corneal center. That symmetry is the key feature. It tells you the astigmatism is regular rather than irregular. The important takeaway is that normal corneas and regular astigmatism produce predictable, symmetric patterns. When that symmetry is lost, or the bow tie becomes distorted or asymmetric, you should start thinking about irregular astigmatism or corneal pathology. This slide is pointing out an important pitfall when interpreting corneal topography, especially bow tie patterns. The bow tie appearance you see on placido-based topography is not purely a reflection of true corneal shape. Part of that pattern is an artifact created by the way placido imaging works. Placido systems rely on reflected rings and cannot directly measure curvature at the very central point of the cornea. Because the central point isn't directly measured, the system has to interpolate that region. The result is an apparent flattening in the center of the map, with exaggerated steepening just away from the center. This effect can make bow tie patterns look more dramatic than the true corneal curvature would suggest. That's why it's important to recognize this as an imaging artifact rather than true pathology. If you're not aware of this limitation, it's easy to overinterpret central curvature changes or assume abnormal flattening that isn't actually there. The key takeaway is that bow tie patterns should always be interpreted in context, with an understanding of how placido imaging generates the data and where it can mislead you.
Now we'll talk about irregular astigmatism and how it's detected, both clinically and with imaging. Irregular astigmatism refers to non-uniform corneal steepening, where the cornea doesn't have a single, clean axis of curvature. Because of that, it cannot be fully corrected with standard cylindrical lenses. From a visual standpoint, this leads to decreased corrected distance visual acuity, reduced contrast sensitivity, and, depending on severity, increased visual aberrations. Patients often report blur or distortion that persists even with their best refraction. In terms of optical correction, rigid gas-permeable lenses can improve vision by masking the irregular corneal surface with a smooth tear film. This is an important diagnostic clue because improvement with an RGP lens suggests a corneal rather than lenticular source of blur. On topography, irregular astigmatism shows up as non-orthogonal steep and flat meridians, meaning they're not 90 degrees apart, and as asymmetry between the superior and inferior cornea or between the nasal and temporal sides. It's important to remember that these patterns are not always pathological and need to be interpreted in clinical context. Wavefront analysis adds another layer by identifying higher-order aberrations such as coma, trefoil, quadrifoil, and secondary astigmatism. These aberrations help explain why vision quality is reduced and why standard cylindrical correction is insufficient. This slide focuses on why irregular astigmatism matters clinically, especially when you're evaluating patients for keratorefractive surgery. From a surgical standpoint, the most important step is differentiating regular from irregular astigmatism. Regular astigmatism can be treated predictably, while irregular astigmatism raises concern for underlying corneal pathology and can significantly change surgical planning. Conventional excimer laser ablation is designed to correct sphere and cylinder. It does not reliably correct irregular astigmatism. If irregularity is present and not recognized, surgery may improve refractive error on paper, but leave the patient with poor visual quality. In selected cases, topography-guided ablation can help improve irregular astigmatism, but only when the irregularity is not due to early ectasia. This distinction is critical because treating an ectatic cornea with laser ablation can worsen the underlying problem. The map shown on the right illustrates this issue. Instead of a symmetric bow tie with orthogonal axes, the steep and flat areas are non-orthogonal and asymmetric. Patterns like this suggest irregular astigmatism and may indicate pathology that would contraindicate refractive surgery. The key takeaway is that irregular astigmatism is not just a refractive issue, it's a screening diagnosis. Recognizing it can prevent inappropriate surgery and long-term visual harm. To finish this section, it's important to recognize the measurement limitations of corneal topography, so we don't overtrust a single map. Topography accuracy varies depending on the algorithm being used, and even on manufacturer-specific terminology.
Two systems can analyze the same cornea and produce slightly different results, which means values aren't always interchangeable. Tear film irregularities are one of the biggest sources of error. Considerable distortion can occur if the tear film is unstable, leading to maps that look abnormal even when the cornea itself is structurally normal. Misalignment during image capture is another common issue. Poor centration can falsely suggest corneal apex decentration and can mimic patterns that raise concern for keratoconus. This is why patient positioning and repeatability matter so much. There is also inherent test-to-test variability. A single measurement should never be interpreted in isolation, especially if the findings are borderline or unexpected. Trends and repeat scans are far more informative than one data point. Finally, corneal topography is relatively insensitive to focus errors compared with other imaging modalities. While that can be an advantage in some situations, it also means topography alone may miss certain issues that are better detected with complementary imaging. The overarching takeaway is that corneal topography is a powerful tool, but it's not infallible. Understanding its limitations is just as important as knowing how to read the maps themselves.
This slide highlights additional limitations of corneal topography related to coverage and postoperative changes. First, corneal topography has a limited area of coverage. It does not fully assess the very central cornea or the far peripheral and limbal regions, which means important information can be missed in those areas. Simulated keratometry, or SIM-K, also becomes less reliable, especially after refractive surgery. Because SIM-K is derived from assumptions about anterior corneal curvature, surgical alteration of the cornea can significantly reduce its accuracy. Topography is also less reliable for evaluating posterior corneal elevation. This is particularly true for scanning slit-based technologies, where accuracy can be affected by corneal opacities and changes in light transmission. After refractive surgery, posterior elevation measurements are commonly degraded, making it harder to accurately assess posterior corneal shape and stability using topography alone. The overall takeaway is that while corneal topography is invaluable, its limited coverage and reduced accuracy in the postoperative setting mean it should be complemented with other imaging modalities when detailed or posterior corneal assessment is required.
Up to this point, we've been talking about corneal topography, which really focuses on the front surface of the cornea and tells us about anterior curvature and power. That's extremely useful, but it's also only part of the story. This slide is where we make the shift from topography to tomography. Placido-based topography does its best work when we want to understand the anterior corneal surface, because it's essentially analyzing reflected rings off the tear film to estimate curvature and power. What it does not do well is tell us what's happening deeper in the cornea. Tomography, on the other hand, is designed to describe the overall corneal shape. It reconstructs the cornea in 3 dimensions, which means it includes spatial thickness profiles and directly measures both the anterior and posterior corneal surfaces. That posterior surface information is something topography simply cannot give us. Tomographic systems rebuild the cornea using multiple slit images, allowing a true structural reconstruction rather than an inferred surface map. The main technologies that do this include scanning slit systems, Scheimpflug-based imaging, and anterior segment OCT. Anterior segment OCT adds another layer of value by providing epithelial thickness mapping, which is particularly useful in refractive surgery planning and in detecting early or subtle corneal pathology that may be masked on surface-based maps. So conceptually, think of topography as a surface map and tomography as a 3D model. From here on, we're focusing on tomography because it gives us a more complete and clinically robust understanding of corneal structure.
Now that we've shifted into tomography, this slide explains how elevation maps actually work. Instead of describing curvature or power, elevation mapping shows the shape of the cornea using height, or z-height. Every point on the cornea is assigned a height value and displayed with a color map. Importantly, that height is not absolute. It's measured relative to an arbitrary reference plane, like the iris plane. For clinical interpretation, we don't usually look at raw height. Instead, elevation maps are displayed as differences from a best fit sphere, or sometimes another reference surface that approximates a normal cornea. In other words, the map answers the question, how much does this cornea deviate from an idealized shape?
Each tomographic device calculates its own best fit sphere for every map. That's a key point. Because the reference surface is recalculated by the device, elevation values are inherently relative, not absolute. As a result, elevation maps from different devices cannot be compared precisely to one another. Apparent differences between maps may reflect differences in reference geometry rather than true changes in corneal shape. The takeaway is that elevation maps are powerful for detecting localized protrusion or asymmetry, but they must always be interpreted in the context of the reference surface being used, and comparisons should be made within the same device, not across platforms.
Let's walk through this figure step by step and think of it as a simple way to understand what an elevation map is actually showing. What elevation mapping is doing is asking a very basic question. How high or how low is the cornea compared to something we choose as a reference? Starting with panel A, here the cornea is being compared to a flat reference plane. On the left, the flat plane is lined up with the corneal apex, which is the very center of the cornea. On the right, the flat plane is lined up with the limbus, closer to the edge of the cornea. The labels Z1 and Z2 are just height measurements. When the cornea sits behind the reference plane, that height value is negative, like Z1. When the cornea sticks out in front of the reference plane, the height is positive, like Z2. The important point is that the cornea itself has not changed at all. The only thing that changed is where we place the reference plane, and that alone changes the measured height.
Now move to panel B. Instead of using a flat surface, the cornea is compared to a reference sphere. One sphere is flatter, labeled R1, and the other is steeper, labeled R2. When the cornea is compared to the flatter sphere, it may sit below that surface, giving a negative height value like Z3. When the same cornea is compared to a steeper sphere, it may sit above that surface, giving a positive height value like Z4. Again, nothing about the cornea itself is different. Only the reference shape has changed. The key takeaway from this figure is that elevation maps do not show absolute height. They show height relative to a chosen reference, whether that reference is a flat plane or a best fit sphere. Because different devices and algorithms choose different reference geometries, elevation maps from different systems cannot be directly compared, and apparent differences may reflect the reference choice rather than true corneal shape change.
Here, we're shifting from how elevation maps are made to why we actually care about them clinically. Elevation-based tomography is especially valuable when we're evaluating patients for refractive surgery. Unlike placido topography, which mainly reflects the anterior surface, elevation-based systems let us see the true three-dimensional shape of the cornea. These systems accurately show both the anterior and posterior corneal surfaces, which is critical because early disease or surgically induced changes often show up on the posterior surface first. They also allow assessment of lens surface geometry, which adds another layer of structural information that curvature maps alone can't provide.
Because elevation maps are based on actual spatial position rather than averaged curvature, they improve our ability to detect subtle shape abnormalities. That includes very early ectatic changes, as well as small but meaningful postoperative structural changes that might be missed on axial maps. Finally, elevation-based tomography allows more accurate longitudinal follow-up. When we're comparing scans over time, especially after refractive surgery, elevation data is better suited to detecting true corneal alterations rather than changes caused by smoothing, scaling, or reference axis assumptions. This makes it a powerful tool for both preoperative screening and postoperative monitoring.
This slide is really about why corneal imaging is non-negotiable before refractive surgery. Corneal imaging is an essential part of the preoperative refractive surgery evaluation because it helps us decide who is safe to treat and who is not. We're not just measuring refractive error here, we're screening corneal structure. In normal corneas, about 2/3 show symmetric astigmatism that can look round, oval, or like a classic symmetric bow tie pattern. These patterns are centered, balanced, and mirror each other across a single axis. When you see that kind of symmetry, it's generally reassuring. What raises concern are asymmetric patterns. An asymmetric bow tie, where one side is steeper than the other, suggests uneven corneal shape. Inferior or superior steepening is particularly important because localized steepening, especially inferior, can be an early sign of ectatic disease.
Skewed radial axes, where the steep axes are not 180 degrees apart, also suggest irregular biomechanics rather than simple astigmatism. And finally, nonspecific irregularities, maps that just look messy without a clear pattern, should always make you pause. The key point is that symmetric patterns are common and usually benign, while asymmetry is what triggers deeper evaluation, often with tomography and posterior surface analysis, before considering refractive surgery.
This slide focuses on how topography detects irregular astigmatism and why context matters. Corneal topography can show irregular astigmatism from several causes. Common reversible causes include an abnormal tear film and contact lens warpage, both of which can distort placido rings and mimic true corneal irregularity. More concerning causes include keratoconus and other ectatic disorders, prior corneal surgery, trauma or scarring, and post-inflammatory or degenerative disease. When the etiology isn't clear, repeat imaging is often necessary, especially in contact lens users or patients with tear film instability. Stopping contact lens wear before evaluation allows the cornea to stabilize, leading to more reliable refraction and more accurate topography maps. Eyes with keratoconus or other ectatic disorders are not routine candidates for ablative keratorefractive surgery. The main concern is an unpredictable refractive response and the risk of progressive postoperative ectasia. Even form fruste, subclinical keratoconus, is typically treated as a contraindication to ablation because removing tissue can destabilize a cornea that's already biomechanically weak. There is growing interest in combined approaches where keratorefractive procedures are paired with corneal cross-linking to improve stability. However, these strategies are still under investigation, and long-term safety and patient selection are not yet fully established.
After surgery, corneal imaging becomes a way to measure what actually changed. Topography and tomography let us assess the effects of refractive surgery on corneal shape and power. By comparing preoperative and postoperative maps, we can determine the achieved refractive change, often using difference maps to visualize where tissue was altered. Postoperative imaging is also key for explaining unexpected outcomes, such as undercorrection or overcorrection. It helps identify induced astigmatism and higher-order aberrations related to small optical zones, decentered ablations, or central islands, which may not be obvious on refraction alone.
This figure shows Scheimpflug tomography difference maps used to compare the cornea before and after myopic LASIK. On the left is the preoperative map, showing a relatively steeper central cornea, which is what we expect in myopia. In the middle is the postoperative map, where the central cornea is flatter after laser ablation. On the right is the key panel, the difference map, which subtracts the postoperative data from the preoperative data. This isolates the true corneal power change caused by surgery. The central blue area represents flattening, corresponding to the myopic correction, while the surrounding colors show how that change transitions toward the periphery. Difference maps are especially useful because they remove baseline anatomy and let us focus on what actually changed, rather than what the cornea looked like at a single time point. Clinically, this helps confirm whether the intended refractive effect was achieved and whether the ablation was centered, symmetric, and appropriately sized. This figure shows post-ablation corneal topography after excimer laser treatment, highlighting two common causes of postoperative visual symptoms. On the left, this is a small optical zone after ablation. You can see a relatively flat central blue area, which represents the treated zone, surrounded by a steep peripheral ring. The key issue here is that the optical zone is smaller than the functional pupil, especially in mesopic or scotopic conditions. When the pupil expands beyond the treated area, light passes through the untreated, steeper peripheral cornea, which can lead to halos, glare, and reduced night vision.
On the right, this map shows a decentered ablation. Instead of the flattening being centered on the visual axis, the blue flattened zone is shifted off-center. This creates an asymmetric curvature pattern, which induces irregular astigmatism and higher-order aberrations, particularly coma. Clinically, this often presents as ghosting, smearing, or directional blur that cannot be fully corrected with glasses. Together, these maps illustrate how postoperative topography helps identify why vision may be suboptimal, even when the refraction looks close to plano.
Small optical zones and decentered ablations are classic structural causes of postoperative visual complaints that are best understood through corneal imaging rather than refraction alone.
This slide focuses on the stroma, which is where most of the cornea's mechanical strength comes from. The corneal stroma is the primary structural component of the cornea and makes up most of its thickness. It's composed of collagen fibrils organized into roughly 200 lamellar sheets, forming a highly ordered collagen network rather than a random mesh. These lamellae run parallel to the corneal surface, and adjacent layers are oriented at alternating angles. That crossed arrangement is key. It allows the cornea to resist deformation from forces in multiple directions while maintaining optical clarity. In the posterior two-thirds of the stroma, the collagen organization becomes more regular, with predominant fiber orientations in the vertical and horizontal directions. This regional organization helps explain why corneal biomechanics vary by depth.
Now we can contrast the anterior and posterior stroma because they are not biomechanically equivalent. The anterior stroma has greater fiber branching and interweaving. That complex, interlaced architecture makes it biomechanically stronger and better at resisting deformation. In practical terms, this is the part of the cornea that contributes disproportionately to overall structural integrity. The posterior stroma, by comparison, has a more uniform fiber orientation. While it's still structurally important, it is relatively less biomechanically robust than the anterior stroma. This distinction becomes especially important in keratoconus. In the cone region, branching fibers are sparse, which leads to localized stromal weakness and explains why deformation occurs in a focal, asymmetric pattern rather than diffusely. These anterior-posterior differences are critical when we think about refractive surgery. Procedures like LASIK, PRK, and SMILE interact with different stromal depths, so understanding where the cornea is strongest and where it is most vulnerable directly informs risk assessment and surgical decision-making.
This slide ties stromal composition to hydration and, ultimately, how mechanical stress is handled. The glycosaminoglycan composition of the stroma differs between the anterior and posterior layers. That biochemical difference matters because it directly influences how each region interacts with water. The posterior stroma contains more hydrophilic proteins. As a result, it plays a larger role in swelling behavior and has different load-bearing properties compared to the anterior stroma. Under normal hydration conditions, mechanical stress is distributed relatively evenly across the depth of the stroma. No single layer is disproportionately overloaded, and the cornea maintains its normal shape and clarity. In corneal edema, that balance breaks down. The anterior lamellae end up bearing most of the mechanical stress, while the posterior fibers become lax. Clinically, this shift in stress manifests as stromal folds that can extend all the way to decimate membrane, linking the biochemical changes of hydration to the structural findings we see on exam.
Up to this point, we focused on why the cornea behaves the way it does. Now the question becomes how we actually measure that behavior in a clinical setting. The goal of biomechanic evaluation methods is to directly assess corneal biomechanics, particularly before refractive surgery. Rather than inferring risk from shape alone, these tools aim to characterize how the cornea responds to applied force. This approach helps differentiate healthy corneas from abnormal ones, including eyes that may appear topographically normal but are biomechanically vulnerable. As a result, these technologies add another layer of safety to preoperative screening. The available technologies are still evolving, but current devices share a common principle. They rely on bidirectional, non-contact applanation tonometry to apply a controlled air pulse, and then analyze corneal deformation using Scheimpflug imaging. By capturing how the cornea deforms and recovers in real time, these systems provide indirect but clinically useful insight into corneal biomechanical properties. We can break down the basic mechanics behind non-contact bidirectional applanation. These systems use a focused air jet to deform the cornea in a controlled and repeatable way. As the air pulse increases, the cornea is pushed inward, and the device records the pressure at the moment the cornea first flattens. This is the first applanation, occurring as the cornea moves inward.
As the air pressure then decreases, the cornea rebounds from a concave shape back toward its normal configuration. The point at which it flattens again is the second applanation, and this happens at a lower pressure than the first. The key measurement here is the difference between those two pressures. That difference is corneal hysteresis, or CH. Corneal hysteresis reflects the viscous, time-dependent energy dissipation of the cornea, capturing how much energy is absorbed and lost as the tissue deforms and recovers, rather than being perfectly elastic. Think of this test like gently flicking the cornea with a puff of air and watching how it reacts, and this can be measured as shown in this graph. The green curve shows the air puff getting stronger and then fading away. As that air hits the cornea bends inward and then springs back out. The red and blue curves show how the cornea is moving during that in and out motion. When the cornea moves inward, it briefly becomes flat. That moment is the first peak. Then the cornea keeps bending, forms a little bowl shape, and starts to come back out. When it becomes flat again on the way back, that's the second peak. In a normal cornea, those two peaks are tall, clear, and very similar each time you measure them. That tells us the cornea is firm and responds in a predictable way. In keratoconus, the peaks are shorter and messier. The cornea bends more easily and doesn't snap back as cleanly, so the signals look smaller and noisier. The space between the two peaks is called corneal hysteresis. You can think of it as how much energy the cornea loses while bending and unbending. A healthy cornea holds on to its strength, while a weaker cornea loses more energy as it moves. Now we can translate that air puff test into specific numbers that we actually use clinically. The first metric is corneal hysteresis, as we talked about in the past slides. This tells us how stretchy and shock-absorbing the cornea is. A lower CH means the cornea loses more energy when it bends, which is why low CH is associated with keratoconus. It's also important in glaucoma because a low CH is an independent risk factor for progressive visual field loss. Next is Goldman correlated intraocular pressure, or IOPG. This value is simply the average of the two pressures measured during inward and outward applanation. It's designed to approximate what we'd get with Goldman tonometry. Then there's corneal compensated intraocular pressure, or IOPCC. This measurement adjusts for the cornea's biomechanical properties, so it's less influenced by how thick the cornea is. The goal is to get closer to the true intraocular pressure, regardless of corneal thickness. Finally, we have the corneal resistance factor, or CRF. This reflects the overall resistance to the air puff and is weighted more toward elastic, instant responses rather than time-dependent behavior. You can think of CRF as how stiff the cornea is at that moment, while CH tells us how it handles energy over time. This slide moves beyond pressure numbers and focuses on how the cornea actually moves in real time. Scheinflug-based deformation analysis uses ultra-high-speed Scheinflug imaging to capture the cornea during an air puff indentation. Instead of just recording when the cornea flattens, the system continuously monitors how the cornea bends inward and then recovers. From that motion, it can measure several dynamic properties, including how fast the cornea moves, how much it deforms, and the exact timing of each phase of applanation. These parameters give much more detailed biomechanical information than a single pressure value. The key advantage is that this approach provides a dynamic assessment of corneal behavior. Rather than treating the cornea as a static surface with a pressure reading, it evaluates how the cornea responds to force over time, which is far more reflective of its true biomechanical properties.
This slide brings everything together in the context of refractive surgery. Corneal biomechanics are central to keratorefractive surgery outcomes because these procedures don't just change corneal shape, they alter how the cornea bears and redistributes stress over time. Different procedures produce different biomechanical responses based on two main factors. The first is how much tissue is removed or dissected. The second is where in the stroma that alteration occurs, particularly whether the stronger anterior layers are disrupted or preserved. Because of these differences, the biomechanical load placed on the cornea varies substantially between surgical techniques. That variation helps explain why procedures with similar refractive goals can have very different long-term stability and risk profiles, especially in eyes that are already biomechanically vulnerable.
Here, we can compare how different refractive procedures alter the cornea biomechanically. With LASIK, the procedure begins by creating a corneal flap, either with a microkeratome or a femtosecond laser. After the flap is lifted, excimer laser ablation thins the stromal bed. This approach disrupts the anterior stromal lamellae, which are the layers that contribute most to corneal strength, and that disruption explains much of LASIK's biomechanical impact. PRK works differently. The laser is applied directly to the anterior stroma, and there is no flap creation. Although tissue is still removed, the absence of a flap changes how stress is redistributed across the cornea compared with LASIK. SMILE takes yet another approach. A femtosecond laser creates a three-dimensional intrastromal lenticule, which is then removed through a small 2 to 5 millimeter incision. Because there is no large flap, the anterior stromal lamellae are largely preserved, except at the incision site, resulting in a different biomechanical profile from both LASIK and PRK.
This slide focuses on how biomechanical differences translate into stability and ectasia risk after refractive surgery. Because SMILE preserves more of the anterior stroma, it may provide greater biomechanical stability compared with flap-based procedures. The idea is that keeping the strongest stromal layers intact helps the cornea better resist long-term deformation. Some studies support this, showing higher corneal hysteresis and higher corneal resistance factor after SMILE when compared with LASIK or LASIK. These findings suggest a cornea that absorbs energy better and resists deformation more effectively. The likely explanation is straightforward. The stiffer anterior stroma is largely maintained in SMILE rather than being disrupted by a flap. However, it's important to be clear about the limitation. Postoperative ectasia has still been reported after SMILE, and no refractive procedure completely eliminates ectasia risk. Biomechanics can be optimized, but they can't fully override underlying corneal vulnerability.
This slide steps back and states the core principle that underlies all keratorefractive surgery. Every keratorefractive procedure corrects refractive error by altering corneal curvature. No matter how different the techniques may seem, the end goal is the same: changing the shape of the cornea so light focuses properly on the retina. What varies is the method used to create that change. The approach depends on the specific surgical technique, as well as the type and magnitude of the refractive error being treated. There are several broad ways this can be done. Some techniques rely on incisions to redistribute corneal tension. Others subtract tissue to reshape the cornea, add tissue to change curvature, or introduce alloplastic material. Laser ablation is another major approach, using controlled tissue removal to achieve the desired refractive effect. All of these methods ultimately converge on the same biomechanical outcome, reshaping the cornea, but they do so with very different implications for corneal structure and stability.
This slide focuses on the direction of corneal shape change required for different refractive errors. For myopia correction, the goal is to flatten the central cornea. Flattening reduces the cornea's focusing power, which moves the focal point back onto the retina. In biomechanical terms, this corresponds to a decrease in central corneal curvature. For hyperopia correction, the opposite change is required. The central cornea needs to be steepened to increase its focusing power, which brings the focal point forward onto the retina. This results in an increase in central corneal curvature. Because these shape changes are fundamentally different, surgical planning has to account for how each technique reshapes the cornea to produce the intended optical effect. The same procedure can behave very differently depending on whether the goal is flattening or steepening, with important biomechanical consequences.
This slide connects corneal shape to what patients actually experience after surgery. Patient satisfaction depends on more than just hitting the refractive target. It also depends on creating a corneal shape that optimizes visual quality, not just visual acuity. In a normal eye, the cornea has a prolate shape, meaning it is steeper in the center and flatter in the periphery. This produces an aspheric optical system that minimizes aberrations and supports high-quality vision. After surgery, the cornea can become oblate, which is a shape we often see postoperatively. An oblate cornea increases spherical aberration, and that optical change is associated with symptoms like glare, halos, and reduced contrast sensitivity. These changes in corneal shape help explain why some patients report visual symptoms despite achieving good Snellen acuity.
The optics may be technically corrected, but the quality of vision can still be compromised.
This slide introduces the basic principles behind incisional refractive techniques. Corneal incisions that are placed perpendicular to the corneal surface can change corneal shape by altering how tension is distributed within the stroma. The magnitude and direction of that shape change depend on several factors, including the direction of the incision, how deep it is, where it's placed, how long it is, and how many incisions are made. One unifying rule is that all corneal incisions cause local flattening at the site of the incision. What differs is how that flattening affects the rest of the cornea. With radial incisions, the meridian of the incision itself flattens, and there is also flattening in the meridian 90 degrees away. This produces a more symmetric redistribution of corneal curvature. Tangential or arcuate incisions behave differently. They flatten the meridian of the incision, but instead of flattening the perpendicular meridian, they cause steepening 90 degrees away. That opposing effect is why arcuate incisions are particularly useful for managing astigmatism. Understanding these directional effects is critical because small changes in incision placement can produce very different refractive outcomes.
This slide explains the coupling effect in incisional refractive surgery. When a tangential incision is made, it flattens the meridian where the incision is placed. At the same time, the meridian 90 degrees away becomes steeper. That steepening may be equal to or less than the amount of flattening in the primary meridian. This linked response between the two meridians is called coupling.
Coupling is important because it means you can change astigmatism without necessarily causing a large change in overall spherical power, depending on how balanced the flattening and steepening are. The strength of the coupling effect can be modified clinically. A smaller optical zone increases the effect, particularly with radial incisions. For tangential incisions, placing the incision closer to the visual axis increases the effect. Increasing the arc length also increases the effect, with tangential incisions typically effective up to about 3 clock hours. Understanding coupling allows more predictable control of astigmatic correction when planning incisional procedures.
This picture is showing different ways surgeons place cuts in the cornea to fix astigmatism. Think of the cornea like a flexible dome. If you make a cut in it, the cornea relaxes in that direction and becomes flatter there. At the same time, the cornea tightens in the direction 90 degrees away and becomes steeper. On the left are arcuate incisions. These are curved cuts placed partway around the cornea. They flatten the cornea along the direction of the cuts, which in this example is vertical, and cause steepening in the horizontal direction. In the middle are tangential incisions. These are straighter cuts that work the same way. They flatten the cornea in the direction of the incision and steepen it 90 degrees away. On the right are limbal relaxing incisions. These are placed more toward the edge of the cornea, near the limbus. They still follow the same rule: flatten where the incision is made and steepen 90 degrees away. But because they're farther from the center, their effect is usually gentler. The key idea is that incisions don't just change one direction. Every cut causes a paired response, flattening in one meridian and steepening in the perpendicular meridian. And that paired response is what lets surgeons fine-tune astigmatism.
This slide explains why incision depth matters and what predicts how strong the effect will be. The optimal incision depth is about 85 to 90% of corneal thickness. At this depth, the posterior lamellae remain intact, while the anterior lamellae are allowed to bow and relax the most. That balance maximizes the refractive effect without fully destabilizing the cornea. Surgical planning often relies on nomograms. In theory, these effects can be modeled using finite element analysis, but in practice, most surgical nomograms are empirically derived from clinical outcomes rather than purely biomechanical models. Several factors reliably predict the strength of the effect. These include the patient's age, the number of incisions, how deep they are, and how long they are. For the same incision pattern, older patients tend to have a greater effect, likely due to age-related changes in corneal biomechanics. In contrast, intraocular pressure and preoperative corneal curvature are not reliable predictors of how much an incision will produce, which highlights the importance of technique and patient-specific factors over baseline measurements.
This slide highlights how modern technology has refined incisional refractive surgery. Femtosecond lasers allow surgeons to create arcuate incisions with a high level of precision.
Unlike manual techniques, the laser gives tight control over arc length, depth, and exact location within the cornea, which directly improves predictability. These capabilities enable femtosecond laser-assisted astigmatic keratotomy, or AK. A key advantage is iris registration, which compensates for cyclotorsion when the patient moves from an upright to a supine position. This improves alignment so the incision is placed on the intended meridian. Clinically, these advances translate into good refractive outcomes with a low risk of complications. The precision of femtosecond delivery reduces the risk of wound dehiscence and minimizes the chance of corneal perforation, making modern incisional techniques both safer and more predictable than earlier approaches.
Femtosecond laser-assisted astigmatic keratotomy, FLAC, is an incisional surgical procedure in which arcuate incisions of about 80 to 90% depth are made in the steep meridian of the mid-peripheral cornea at the 7 to 9 millimeters optical zone. FLAC, AKs, and LRIs are similar in that both have coupling ratios of 1. Therefore, correct astigmatism without inducing a significant hyperopic shift. Several femtosecond laser platforms have been approved for incisional keratotomies. The femtosecond laser incisions can be either anterior penetrating or interstromal. This is a case of a 62-year-old female that underwent penetrating keratoplasty for a corneal ulcer 15 years ago. The patient presented with a significant residual withdrawal astigmatism with no signs of graft ectasia. As we can see here, the femtosecond laser incisions are initially centered at the limbus. However, to assure centration in this case, the incisions were manually moved inside the graft. The femtosecond laser landmarks for anterior cornea, anterior and posterior lens may need to be manually adjusted. At this point, we approved the real-time spectral domain OCT anatomical landmarks, and the treatment was performed in 9 seconds. Thank you very much.
This slide shifts briefly into historical context to explain where modern refractive surgery ideas came from. Aside from laser ablation, most tissue addition or subtraction techniques are now mainly of historical interest. They're not commonly used today, but they were critical in shaping how we think about refractive correction. A key example is keratomalesis, originally described by Barricare. The core idea was mechanically carving the anterior cornea to change its shape. By subtracting tissue, surgeons could alter either spherical or meridional curvature, and these procedures were performed on otherwise healthy corneas. While crude by today's standards, these techniques introduced the fundamental concept that refractive error could be corrected by reshaping the cornea itself. That conceptual leap laid the groundwork for modern refractive surgery and directly influenced the development of laser-based procedures we use today. This slide reviews tissue addition techniques, which take a fundamentally different approach from laser ablation. Epikeratoplasty, also called epikeratofakia, involves placing a precision-lathe donor lenticule onto the surface of the cornea. By adding tissue rather than removing it, this technique can induce either hyperopic or myopic refractive changes, depending on the shape of the lenticule. Keratophakia works on a similar principle, but places the tissue deeper. In this approach, a tissue lenticule or a synthetic inlay is implanted within the stroma rather than on the surface. This intrastromal placement alters corneal curvature from within. Both techniques rely on adding tissue to reshape the cornea rather than subtracting tissue. Although these methods are now largely historical or limited to select indications, they reinforce the broader concept that refractive error can be corrected by either removing or adding corneal tissue to change curvature. This slide brings us back to tissue subtraction, but in a modern form. There has been renewed interest in subtracting tissue without using excimer laser ablation. Instead of removing tissue from the surface, these newer approaches reshape the cornea from within. Current procedures include refractive lenticular extraction, or RELAX, femtosecond lenticular extraction, or FLEX, and small incision lenticular extraction, known as SMILE. While the names differ, they all share the same fundamental mechanism. All of these techniques use a femtosecond laser to create an intrastromal lenticule with a precise shape. That lenticule is then removed, and its removal changes the corneal curvature to correct the refractive error. Conceptually, this represents a shift away from surface ablation toward intrastromal reshaping. The refractive effect is still achieved by tissue subtraction, but the biomechanical and healing implications differ because the corneal surface and much of the anterior stroma are preserved.
Now, let's talk about alloplastic material addition, specifically how adding material to the cornea can change its shape or optical properties without removing tissue. The core idea here is that corneal shape can be changed by adding material rather than removing tissue. In alloplastic procedures, a synthetic material, most commonly a hydrogel, is placed within the corneal stroma. This added material can alter the anterior corneal curvature or, in some cases, change the effective refractive index of the cornea. The key distinction is that refractive change is achieved through structural augmentation, not tissue subtraction, which sets these techniques apart from laser-based refractive surgery.
Intrastromal corneal ring segments, or ICRS, are alloplastic implants placed within the corneal stroma. They're typically inserted as two arc-shaped segments into stromal pockets rather than forming a complete ring. The key idea is mechanical reshaping. By adding volume in the mid-peripheral cornea, these segments change the corneal surface contour. The magnitude and pattern of that change depend on the segment's profile, thickness, and exact location within the cornea. The net effect is central corneal flattening, which can reduce irregular astigmatism and improve corneal symmetry. Clinically, ICRS are most commonly used in ectatic corneal disorders, such as keratoconus, and in select refractive situations where tissue subtraction is not ideal.
Now, let's shift to corneal inlays for presbyopia, which take a very different approach. The most well-known example is the small aperture corneal inlay. Rather than reshaping the cornea, this device works through a pinhole effect, increasing depth of focus and improving near vision. This approach was approved for presbyopia treatment in 2015. Other corneal inlays and onlays were also investigated for presbyopia, but many of these studies were eventually halted. The major limiting factor wasn't optical performance alone, but safety. Several products were withdrawn from the market due to high rates of corneal haze and other biologic responses. Taken together, corneal inlays highlight a recurring theme in refractive surgery. Achieving optical benefit is only part of the challenge. The long-term biologic response of the cornea often determines whether a technology ultimately succeeds or fails.
Now let's talk about collagen shrinkage, which changes corneal shape through biomechanics rather than tissue removal or addition. The key idea here is that corneal biomechanics can be altered by heating collagen. When stromal collagen is heated to a critical temperature, roughly between 58 and 76 degrees Celsius, the collagen fibers contract. That contraction creates localized shortening of collagen lamellae, which in turn leads to changes in corneal curvature. Importantly, nothing is being added to the cornea, and nothing is being removed. Instead, collagen shrinkage reshapes the cornea by redistributing biomechanical tension within the tissue. The cornea responds to this new tension pattern by altering its overall shape. This distinction matters because it explains both the refractive effect and the potential instability seen with procedures that rely on collagen shrinkage rather than permanent structural remodeling.
Now let's apply that biomechanical concept clinically with thermokeratoplasty. Thermokeratoplasty refers to techniques that intentionally heat corneal collagen to induce controlled shrinkage, and the most well-known example is conductive keratoplasty, or CK. The central cornea is generally avoided in these procedures because direct treatment there carries a significant risk of scarring and visual axis compromise. Instead, treatment is applied in the mid-peripheral cornea.
When collagen in the mid-periphery contracts, it creates a tightening effect in that zone. As a result, the untreated central cornea steepens secondarily, producing a refractive change without directly manipulating the visual axis. Historically, this approach was used for low degrees of hyperopia and for presbyopia, particularly in patients seeking a non-ablative option. However, because the refractive effect depends on collagen behavior rather than permanent structural remodeling, durability has been limited. Over time, biologic remodeling and regression have restricted widespread long-term use of these techniques. This slide really reinforces a recurring theme in refractive surgery. Achieving an optical effect is one thing, but maintaining it in the face of corneal biology is the true challenge.
Now we're going to shift into laser biophysics, specifically how lasers interact with tissue in keratorefractive surgery. There are three major categories of laser tissue interactions that are relevant here: photoablation, photodisruption, and photothermal effects. Among these, photoablation is by far the most important for corneal refractive surgery. Photoablation works at the molecular level. Instead of heating tissue, the laser delivers high-energy photons that directly break chemical bonds within the corneal stroma. This allows tissue to be removed in an extremely precise, controlled manner with minimal collateral damage. In refractive surgery, photoablation is typically achieved using excimer lasers, short for excited dimer, or other lasers operating at wavelengths capable of delivering sufficient photon energy.
The key concept is energy per photon. When laser energy reaches approximately 4 electron volts or greater, it becomes strong enough to break carbon-nitrogen and carbon-carbon bonds. Once those bonds are broken, the tissue essentially disintegrates at the molecular level and is removed without significant thermal spread. The other two interaction types, photodisruptive and photothermal, operate through very different mechanisms and serve different clinical purposes, which we'll discuss separately. But for keratorefractive surgery, photoablation is the foundational principle that makes precise corneal reshaping possible. This distinction is critical because it explains why excimer laser ablation can reshape the cornea with micrometer accuracy while preserving surrounding tissue integrity.
Now let's focus specifically on photoablative effects using argon fluoride excimer lasers. Argon fluoride lasers are a type of excimer laser, meaning the laser energy is generated from an excited dimer rather than a stable molecule. In this case, electrical energy is used to excite argon atoms so they transiently form dimers with fluorine gas. When these excited dimers relax back to their ground state, they release light at a very specific wavelength, 193 nanometers. This wavelength sits in the ultraviolet C range, which is high-energy ultraviolet light, and approaches the energy levels seen with X-rays. That wavelength matters because it determines photon energy. At 193 nanometers, each photon carries about 6.4 electron volts of energy. This is well above the threshold needed to break carbon-carbon and carbon-nitrogen bonds within corneal tissue.
Now let's talk about how photoablation actually interacts with tissue and why it's considered so safe. Photoablation uses very high-energy photons, but the key concept is that these photons have extremely low tissue penetration. The energy is absorbed almost entirely at the tissue surface, which is exactly where we want the effect in corneal refractive surgery. Because of this shallow penetration, photoablation is ideally suited for surface-based tissue removal. The laser removes tissue in a highly controlled layer-by-layer fashion, rather than affecting deeper structures. Another critical feature is precision. The excimer laser achieves micrometer-level accuracy with minimal thermal spread. Unlike thermal lasers, there is essentially no heat diffusion into surrounding tissue, which preserves adjacent corneal collagen and cellular structures.
Safety is also strongly tied to wavelength. Although 193 nanometer light is high energy, its penetration is so limited that it does not produce significant cellular lethality beyond the ablation zone. Importantly, this wavelength is considered non-mutagenic. DNA mutagenicity peaks at wavelengths closer to 250 nanometers, where nucleic acids absorb more efficiently. At 193 nanometers, absorption occurs so superficially and rapidly that there is no meaningful accumulation of DNA damage in living cells.
This combination, high photon energy, low penetration, and minimal thermal injury, explains why excimer laser ablation has such a strong safety record despite operating in the ultraviolet range. Finally, it's worth noting that solid-state lasers are capable of generating wavelengths near 193 nanometers without the need for toxic gases like fluorine. However, significant manufacturing and engineering challenges have limited their widespread clinical adoption so far. Taken together, these properties explain why excimer photoablation remains uniquely suited for corneal reshaping. It is precise, predictable, and biologically well tolerated.
Now let's talk about photodisruptive effects and femtosecond lasers. Unlike excimer lasers, which reshape the cornea by removing tissue at the surface, femtosecond lasers work by creating precise tissue separation within the cornea. They deliver extremely short pulses of energy that produce a localized mechanical effect rather than thermal damage. Femtosecond lasers are FDA approved and are used to create LASIK flaps, perform the SMILE procedure, and form intrastromal channels for corneal ring segments. They are also increasingly used in lamellar and penetrating keratoplasty for highly precise corneal cuts. These lasers operate in the infrared range, around 1053 nanometers, which allows energy to be focused deep within transparent tissue. At the focal point, plasma formation and microscopic cavitation bubbles separate tissue planes with excellent depth control. The key idea is that femtosecond lasers are ideal for cutting and separating tissue, while excimer lasers are optimized for reshaping the corneal surface.
This slide explains how photodisruption actually works. When a femtosecond laser is focused into transparent tissue, the energy density becomes high enough to cause photodisruption, meaning the tissue at the focal point is converted into plasma. This process generates extremely high pressure and temperature, but only within a very small, localized volume. That sudden energy release leads to rapid tissue expansion and the formation of microscopic cavitation bubbles inside the corneal stroma. Importantly, there's minimal thermal spread to surrounding tissue. By delivering many contiguous laser pulses, these tiny disruptions can be connected in a precise geometric pattern. This allows surgeons to create structures like a corneal flap, a tissue lenticule for SMILE, intrastromal channels, or highly controlled keratoplasty incisions. The key concept is that photodisruption separates tissue by mechanical forces, not by burning or cutting in the traditional sense.
This slide introduces photothermal laser effects. Photothermal effects are produced by focusing a holmium YAG laser, which operates at a wavelength of 2.13 microns. This wavelength is strongly absorbed by water, so the laser energy is deposited primarily in the anterior corneal stroma. As the water absorbs the energy, it is converted into heat rather than plasma or mechanical disruption. That localized heating causes collagen fibers to shrink, which in turn leads to secondary corneal steepening. Clinically, this mechanism was used in conductive and laser thermokeratoplasty and received FDA approval for low hyperopia. However, because the collagen remodeling is not permanent, the effect tends to regress over time, which is why photothermal techniques are no longer commonly used in modern refractive surgery. Now, let's talk a little deeper about photoablation using the excimer laser. The key idea is that all photoablative procedures physically remove corneal tissue. The refractive change doesn't come from heat or biomechanical remodeling, it comes from precise tissue subtraction at the corneal surface. For myopic treatments, especially with older broad-beam excimer lasers, the amount of central tissue removed can be estimated using the Munnerlin formula. This formula shows that ablation depth increases linearly with the degree of myopia, but increases quadratically with the optical zone diameter. In other words, larger optical zones cost you a lot more tissue. An important concept here is that the effective refractive change is independent of the starting corneal curvature. What matters is how much tissue you remove and over what zone, not whether the cornea started steep or flat. This is why the Munnerlin formula is so useful conceptually. It highlights the fundamental limitations of laser vision correction. Tissue removal is finite, optical zones can't be arbitrarily large, and these constraints ultimately define who is and is not a good candidate for excimer-based refractive surgery.
This slide connects the physics directly to clinical decision-making.
From the Monerlin formula, you can see that the amount of tissue removed increases with the square of the optical zone diameter. So even small increases in optical zone size come at a significant tissue cost. The trade-off is that smaller optical zones increase visual side effects, particularly glare, halos, and regression, because the treated zone may not fully cover the pupil under mesopic or scotopic conditions. Clinically, this is why we generally aim for an optical zone of at least 6 millimeters whenever corneal thickness allows. Larger optical zones improve quality of vision, but they also consume more tissue, which limits how aggressive the correction can be. Ultimately, optical zone selection is a balancing act between optical quality and biomechanical safety, and this balance is central to refractive surgery planning.
This slide highlights where the laser energy is actually applied. With surface ablation, the excimer laser is applied directly to the Bowman layer and anterior stroma without creating a flap. The refractive change is achieved entirely at the surface of the cornea. In LASIK, the first step is a lamellar incision to create a flap. The laser then ablates the underlying stromal bed, and the flap is repositioned afterward. The optical effect is similar, but the biomechanics and healing response are different. Flap thickness matters. Ultra-thin flaps, typically around 80 to 100 microns, preserve more residual stromal bed, whereas standard flaps are thicker, roughly 120 to 180 microns. Importantly, flap thickness and diameter are not fixed values. They depend on the instrument used, as well as corneal diameter, curvature, and overall thickness. This distinction between surface ablation and LASIK becomes critical when balancing visual recovery, biomechanical safety, and ectasia risk.
This slide focuses on how different ablation profiles shape the cornea while preserving tissue. In myopia treatment, the goal is to flatten the cornea, and that's achieved by selectively removing central corneal tissue. Removing tissue centrally reduces the cornea's refractive power. In contrast, hyperopia treatment works in the opposite way. The cornea is steepened by removing tissue in a donut-shaped mid-peripheral pattern, which allows the central cornea to steepen secondarily. Modern excimer platforms use multi-zone treatment algorithms rather than a single abrupt optical zone. These algorithms create multiple concentric optical zones that fully correct the central refractive error while gradually tapering toward the periphery. This approach conserves tissue, reduces symptoms like glare and halos from sharp transitions, and importantly, allows safe treatment of higher degrees of myopia. Overall, multi-zone profiles balance optical quality, biomechanical safety, and tissue preservation, which is central to modern refractive surgery planning.
This figure shows why multi-zone ablation is so important for tissue preservation. On the left is a single-zone treatment correcting 12 diopters of myopia in one pass over a 6.5 millimeter optical zone. Because ablation depth scales with the square of the optical zone, this requires a deep central ablation, about 169 microns. On the right is a multi-zone approach, achieving the same 12 diopter correction, but in stages. 6 diopters are corrected in a smaller 4.5 millimeter zone, 3 diopters in a 5.5 millimeter zone, and the remaining 3 diopters in a 6.5 millimeter zone. By spreading the correction across multiple concentric zones, the total central ablation depth drops to about 103 microns, even though the final refractive result is the same. This illustrates the key advantage of multi-zone algorithms: less tissue removed centrally, smoother peripheral transitions, and improved biomechanical and optical safety, especially in higher myopia.
Once we talk about how much tissue we remove, the next question is how much tissue we must leave behind. After LASIK, stromal tissue is reduced by 2 steps, first by flap creation and then by excimer laser ablation. What remains is the residual stromal bed, and this is critical for long-term biomechanical stability. Historically, surgeons have used 250 microns as a safety threshold for the minimum residual stromal bed. This number is not absolute. It's a guideline rather than a biologic truth. In reality, the exact amount of stromal tissue required to prevent ectasia is not known and likely varies between individuals, depending on corneal biomechanics, geometry, and intrinsic strength. This uncertainty is why modern refractive surgery emphasizes tissue-sparing strategies, conservative planning, and careful patient selection rather than relying on a single numeric cutoff.
Now that we understand how photoablation works, the next question is how that energy is delivered to the cornea. Photoablative excimer lasers aren't all designed the same. They're categorized based on the pattern and method by which laser energy is applied across the optical zone. There are 3 major delivery systems, and each has different implications for accuracy, tissue efficiency, and visual outcomes. Broad beam lasers, scanning slit lasers, and flying spot lasers. We'll go through each of these designs individually in the next few slides.
Broad beam lasers were the earliest excimer laser designs used for corneal photoablation. They use a large diameter beam, sometimes up to about 7 millimeters, which covers most or all of the optical zone at once. Because each pulse delivers very high energy, relatively few pulses are needed to remove tissue. The trade-off is that these systems run at slower repetition rates and rely on optical elements, mirrors or mechanical apertures, such as an iris diaphragm or an ablatable mask, to shape the ablation pattern. So rather than painting the cornea point by point, broad beam lasers remove tissue in a single homogeneous exposure, with the shape controlled mechanically rather than digitally.
Scanning slit lasers represent a step forward in how photoablation is delivered. Instead of treating the cornea with one large beam, these systems generate a narrow slit of laser energy that is scanned across the corneal surface. By moving this slit back and forth, the laser reshapes the cornea in a more controlled way. This scanning motion changes the photoablation profile, which improves the smoothness of the ablated surface and allows for larger optical zones compared with traditional broadbeam systems. Some scanning slit lasers still rely on mechanical iris diaphragms or ablatable masks to shape treatment, while others use projected patterns to guide ablation without physical masking. Conceptually, this approach sits between broad-beam lasers and fully point-by-point systems, combining wider coverage with improved control.
Flying spot lasers represent the most precise approach to photoablation. Instead of a broad beam or a scanning slit, these systems use a very small diameter laser spot, typically on the order of half a millimeter to a few millimeters. That small spot is delivered at a much higher repetition rate and is moved rapidly across the cornea in a point-by-point fashion. Because each pulse removes only a tiny amount of tissue, precise placement becomes critical. For that reason, flying spot lasers require an active tracking system to account for eye movement and ensure the ablation pattern is delivered exactly where intended. Rather than relying on physical masks, these systems use a computer-generated projected pattern, allowing highly customized and smooth corneal reshaping.
In current clinical practice, excimer laser technology has largely converged on a single approach. Most modern systems use either variable spot or flying spot ablation profiles. The unifying idea is precision. Instead of removing tissue in large blocks, these lasers deliver many small, controlled pulses, allowing the ablation pattern to be shaped digitally and adjusted in real time. This shift reflects an emphasis on customization, smoothness of the ablation surface, and accurate compensation for eye movement, which we'll build on as we talk about tracking and wavefront-guided treatments next.
So, why do conventional ablation profiles tend to induce aberrations? It starts with the way tissue is removed. Traditional profiles use relatively small optical and blend zones, especially in myopic corrections. When you remove tissue centrally without adequately transitioning into the periphery, the cornea becomes more oblate rather than maintaining a prolate shape. That shape change matters optically. An oblate cornea disproportionately affects how peripheral light rays are focused, which is why these treatments tend to induce higher-order aberrations, most notably positive spherical aberration, and in some cases coma. There's also a geometric issue. The peripheral cornea is angled relative to the incoming laser beam, so peripheral laser pulses are inherently less efficient than central pulses. Even if the laser delivers the same energy, the effective ablation depth peripherally is reduced. The combination of small blend zones, altered corneal shape, and reduced peripheral ablation efficiency explains why conventional profiles often trade refractive accuracy for optical quality, setting the stage for why modern algorithms focus so heavily on asphericity and customized ablation.
This leads us to wavefront-optimized laser ablation. The key idea here is that the laser algorithm accounts for the natural curvature of the cornea.
Instead of treating the cornea like a flat surface, it recognizes that peripheral laser pulses are less efficient and compensates by delivering more pulses to the periphery. By doing this, Wavefront-optimized treatments minimize the induction of higher-order aberrations, particularly spherical aberration, which we just discussed as a major limitation of conventional profiles. The goal is shape preservation. These treatments help maintain a more prolate corneal shape, which translates clinically into better overall quality of vision and fewer night vision symptoms like glare and halos. Importantly, Wavefront-optimized ablations are programmed using the patient's refraction alone. They are not designed to correct pre-existing higher-order aberrations, only to avoid creating new ones. That simplicity is also their advantage. Compared with Wavefront-guided treatments, they are faster to perform and do not require an aberrometer, reducing cost and complexity while still improving optical outcomes.
Now let's move to Wavefront-guided laser ablation. Unlike Wavefront-optimized treatments, this approach starts with direct measurement of the eye's optical imperfections using a wavefront sensing aberrometer. The system captures both lower-order aberrations, like myopia, hyperopia, and astigmatism, and higher-order aberrations, which are unique to each eye. That aberration data is then transferred electronically to the excimer laser, where it's used to program a highly customized ablation pattern. These patterns are often non-radially symmetric and complex because higher-order aberrations are not evenly distributed across the cornea. It's important to keep the scale in mind here. The amount of tissue removed to correct higher-order aberrations is much smaller than what's required for defocus or astigmatism, but it can still have a meaningful impact on visual quality. The treatment is based on a three-dimensional map that represents the difference between the patient's actual wavefront and the desired ideal wavefront. To deliver that correction accurately, precise registration is critical. That includes compensation for cyclotorsion, pupil centroid shift, and eye movement, using tools like iris or limbal registration and real-time pupil tracking. Finally, because the data transfer from the aberrometer to the laser is direct and electronic, it minimizes transcription errors and preserves the fidelity of the measured aberrations. In short, Wavefront-guided ablation is the most customized approach, aiming not just to preserve optical quality, but to actively correct pre-existing higher-order aberrations.
So what do we see clinically when we compare these approaches? The big picture is that all modern excimer laser techniques perform extremely well. Across multiple studies, more than 90% of treated eyes achieve 20/20 vision or better, regardless of whether a conventional or customized profile is used. When we look strictly at visual acuity, outcomes are remarkably similar between conventional treatments and customized treatments. In other words, if you only measure Snellen acuity, you often won't see a dramatic difference. Where customized treatments begin to separate themselves is in quality of vision, not quantity. Patients treated with Wavefront-optimized or Wavefront-guided profiles tend to report better contrast sensitivity, fewer halos, and fewer night vision symptoms, especially under mesopic or scotopic conditions.
When Wavefront-optimized and Wavefront-guided treatments are compared directly, overall outcomes are also quite similar for the average patient. This is an important point. Wavefront-guided treatment is not automatically superior for everyone. The key exception involves patients who start with substantial preoperative higher-order aberrations. In that subgroup, Wavefront-guided ablation can offer a meaningful advantage because it actively targets aberrations that Wavefront-optimized treatments are designed only to minimize, not correct. So clinically, the takeaway is this. Most patients do very well with either approach, but the choice becomes more important when visual quality, and not just acuity, is the primary concern, or when significant higher-order aberrations are present preoperatively.
Now let's talk about topography-guided laser ablations. Conceptually, this approach sits somewhere between Wavefront-optimized and Wavefront-guided treatments. Like Wavefront-guided ablation, it's a customized treatment, but instead of using whole-eye wavefront data, it relies on manifest refraction combined with detailed corneal topography. In other words, we're specifically targeting corneal surface irregularities, not internal optical aberrations from the lens or vitreous. Clinically, this becomes very useful in eyes where the cornea itself is the dominant source of optical error. Topography-guided ablation can regularize the corneal surface and improve vision in cases of decentered prior ablations, small optical zones, or irregular corneas, including those with subtle asymmetry that isn't well addressed by standard profiles.
Importantly, although this technology was initially reserved for irregular corneas, it is now FDA approved for use in normal corneas as well. This reflects growing evidence that improving corneal regularity alone can meaningfully enhance visual quality.
FDA trial data in myopic eyes, with or without astigmatism, showed excellent performance across safety, efficacy, accuracy, and stability. Over 90% achieved uncorrected distance vision of 20/20 or better, and 95% were within half a diopter of emetropia, which is well within modern refractive surgery benchmarks. One of the most compelling findings is the improvement in contrast sensitivity. At 6 months, patients demonstrated significant gains under both mesopic and photopic conditions, reinforcing the idea that topography-guided treatments may offer advantages in functional vision, not just Snellen acuity. So the key takeaway is that topography-guided ablation is particularly powerful when the goal is corneal regularization, and it has evolved from a niche tool for problem corneas into a mainstream option for enhancing visual quality even in otherwise normal eyes.
Now we need to talk about corneal wound healing, because every keratorefractive procedure ultimately succeeds or fails here. Regardless of the technique, whether it's incisional, surface ablation, or lamellar surgery, all keratorefractive procedures depend on corneal wound healing to achieve and maintain the intended refractive effect. In practice, we're either modifying the wound healing response or deliberately taking advantage of normal wound healing to lock in the correction. Astigmatic keratotomy is a good example of this concept. The incisions initially weaken the cornea, but the long-term effect depends on controlled collagen remodeling. Epithelial plugs are gradually replaced by collagen, and proper remodeling is what stabilizes the effect and helps avoid late hyperopic drift.
In PRK, the biology is very different. The epithelium heals rapidly, and ideally we see minimal keratocyte activation in the anterior stroma. The entire goal is to allow resurfacing while avoiding excessive fibroblast activity, which is what leads to corneal haze and scarring. LASIK relies on yet another wound healing strategy. Early on, the procedure depends on intact epithelium and a healthy endothelium to create a fluid seal of the flap. Long-term stability comes from peripheral wound healing, which secures the flap edge and prevents late displacement. At the same time, the central cornea must remain relatively free of healing, because any significant healing response in the visual axis degrades optical quality. So across techniques, the theme is consistent. We're not just reshaping the cornea, we're carefully engineering where healing happens, how much healing happens, and where it must not happen. This slide focuses on nerves and the cellular response, which are central to how the cornea heals after surgery. Corneal nerve regeneration is not optional, it's essential for normal ocular surface health and visual function. When reinnervation is delayed or abnormal, patients can develop reduced or distorted corneal sensitivity, which directly destabilizes the tear film and leads to dry eye symptoms. This is why nerve injury matters clinically, not just anatomically. At the cellular level, corneal wound healing follows a cascade that depends on the type and severity of injury. When the epithelium is disrupted, signaling molecules trigger keratocyte apoptosis in the anterior stroma. This initial cell loss is expected and sets the stage for repair. The remaining keratocytes then become metabolically active. They begin producing new glycosaminoglycans and new collagen, which remodel the stromal matrix. Whether this remodeling restores optical clarity or degrades it depends on how controlled that response is. Two factors strongly influence the final outcome: how long the epithelium remains defective and how deep the stromal injury extends. Longer epithelial defects and deeper stromal injury increase keratocyte activation and raise the risk of haze and refractive regression. So at its core, refractive surgery isn't just about reshaping the cornea, it's about minimizing unnecessary nerve damage and tightly regulating the cellular healing response that follows. One of the key wound healing complications we worry about after keratorefractive surgery is corneal haze. Corneal haze is fundamentally a manifestation of the wound healing cascade. After corneal injury, particularly surface ablation, activated keratocytes and altered extracellular matrix deposition can reduce stromal transparency. This process is typically localized to the subepithelial anterior stroma, just beneath where the epithelium regenerates. Importantly, haze is not always transient. In some patients, it can persist for several years, especially after surface ablation procedures like PRK. That said, clinically significant haze is uncommon and occurs in only a small percentage of eyes. The risk is not uniform. Haze becomes more likely with deeper ablations, greater surface irregularity, and prolonged epithelial healing time. In other words, the more intense and prolonged the stromal wound healing signal, the higher the likelihood of visually meaningful haze. Despite removal of the Bowman layer in surface ablation, the cornea is still capable of reestablishing strong epithelial adhesion. Hemidesmosomes are normal or even increased, and anchoring fibers form to secure the epithelium to the underlying stroma. In contrast, haze is very rare after LASIK, particularly within the central flap interface. This is likely related to minimal epithelial disruption, reduced keratocyte activation, and possibly the preservation of some intact corneal nerves, which dampens the wound healing signal. Clinically, this slide reinforces a central theme of refractive surgery. Optical outcomes are inseparable from biological behavior, and controlling wound healing is just as important as controlling laser ablation.
LASIK flap healing is intentionally limited, and that has important clinical implications. Unlike surface ablation, LASIK shows incomplete healing between disrupted stroma lamellae over time. Early flap stability does not depend on scar formation. Instead, it relies primarily on negative stromal pressure generated by endothelial pump function and an intact epithelial surface sealing the flap. This limited biological healing persists long-term. Even years after LASIK, the lamellar interface can still be separated, and the flap can be relifted, demonstrating that true stromal fusion never fully occurs. Clinically, this means LASIK flaps remain vulnerable to displacement with significant trauma, even many years postoperatively. This slide highlights a core trade-off in LASIK: excellent optical clarity and minimal haze, achieved by deliberately suppressing wound healing, at the cost of permanent flap dependence on mechanical stability rather than biological adhesion.
Now let's shift to ocular light scatter, or stray light, an important concept in visual quality. Intraocular light scatter arises from reflection, refraction, and diffraction of light as it passes through the eye. It originates not only from the cornea, lens, and retina, but also from light penetrating through the sclera and iris, which contributes to background noise. Functionally, increased scatter reduces light transmission, lowers image contrast, and ultimately degrades retinal image quality, even when visual acuity on the chart appears normal. Clinically, this helps explain why some patients complain of glare or poor night vision despite good Snellen acuity. Scatter can be categorized as forward scatter, which primarily affects image quality and symptoms, and backward scatter, which is easier to measure clinically but correlates less well with patient experience. This sets the stage for why newer technologies focus on quantifying scatter, not just acuity or wavefront error.
Now, let's distinguish forward from backward scatter, because clinically they matter very differently. Forward scatter refers to light that is deviated less than 90 degrees toward the retina. This creates a veiling luminance over the retinal image, which reduces contrast and is a major driver of glare symptoms, especially at night. This is the type of scatter patients actually perceive. Backward scatter, in contrast, is light deviated more than 90 degrees, away from the retina. It reduces the total amount of light reaching the retina, but has less impact on perceived image quality, even though it's easier to observe clinically. Because of this, measuring forward scatter is critical for understanding real-world visual performance. Commercial devices typically use the double pass technique, which quantifies scatter using the Objective Scatter Index, or OSI. OSI reflects contributions from tear film irregularities and loss of ocular transparency, with values ranging from 0 to about 25. Other approaches include optical stray light measurements and psychophysical testing, all aimed at capturing visual quality beyond Snellen acuity.
This figure helps visualize the difference between forward and backward scatter. Incoming light enters the eye and interacts with small particles and irregularities in the ocular media. Backward scatter is light that is reflected back toward the source. It reduces the amount of light entering the eye, but it is not what primarily degrades vision, and it's what we typically see on slit lamp exam. Forward scatter is light that continues toward the retina, but is deflected off-axis.
This creates a veil of stray light over the retinal image, reducing contrast and causing glare, especially at night. Even though forward scattered light still reaches the retina, it does so in the wrong place, which is why forward scatter correlates much more closely with visual symptoms than backward scatter. That's why modern technologies focus on measuring forward scatter, not just what we can see clinically.
Now let's talk about corneal epithelial mapping. The key concept is that the corneal epithelium is not passive. It can actively change its thickness profile to smooth out underlying stromal irregularities. When there is stromal tissue loss, the epithelium often thickens to compensate, effectively masking surface irregularities on topography. In keratoconus, this compensation follows a classic pattern. The epithelium thins over the cone apex, while thickening in the surrounding areas where stromal thinning is present. After myopic LASIK, we see a different response, central epithelial thickening, and the amount of thickening correlates with how much myopia was ablated. The major clinical takeaway is that epithelial remodeling can significantly distort corneal topography, which means surface maps may not reflect the true underlying stromal shape unless epithelial data are considered.
This slide shows how corneal epithelial mapping is performed and why it matters clinically. Epithelial mapping can be obtained using spectral domain OCT, or very high-frequency digital ultrasound, allowing precise measurement of epithelial thickness across the cornea. The epithelium is not passive. It actively reshapes its thickness to mask underlying stromal irregularities. Clinically, this makes epithelial thickness maps useful for early detection of corneal ectasia, identifying corneal warping patterns, and assessing stability after laser vision correction. In the example shown, typical for keratoconus, the epithelium is thinned over the cone and thickened in the surrounding areas, effectively camouflaging the stromal abnormality on standard topography. Because of this compensatory behavior, epitheliomapping provides information that topography alone can miss, making it a powerful adjunct in refractive screening and postoperative assessment.
Thank you for your attention. We covered the biomechanical and optical principles underlying keratorefractive surgery, how laser platforms and ablation profiles have evolved, and why wound healing, higher-order aberrations, scatter, and epithelial remodeling all matter for real-world visual quality, not just Snellen AQA. The key takeaway is that modern refractive surgery is no longer just about correcting refraction, but about optimizing image quality, stability, and long-term corneal health through increasingly precise and individualized approaches.